Hello, everyone. I think we'll get started with some introductory information. Welcome to today's webinar, Care Planning Practices and Caring for Vulnerable Adults with Multiple Chronic Conditions and the Changing Landscape of Palliative Care. This webinar series is coordinated by the Aging Initiative, which is an R24-funded initiative that brings the expertise and leadership of two powerhouses for research on multiple chronic conditions. The powerhouses are the Healthcare Systems Research Network, formerly called the HMO Research Network, and NIH-funded Claude D. Older Americans Independent Centers, or PEPPER Centers. The Aging Initiative is led by Dr. Jerry Gerwitz at University of Massachusetts and Myers Primary Care Institute, along with co-PIs Elizabeth Bayless and Jay Magaziner. My name is Leah Hanson. I'm a senior research investigator at HealthPartners, and I co-lead the Aging Initiative's Dissemination Workgroup along with Heather Whitson at Duke University PEPPER Center. Before we get started, I need to cover just a few technical details. Due to the number of registrants for today's webinar, we placed all the phone lines on mute to reduce audio feedback, so unless you're logged in as a host or a panelist, your line is muted. However, we definitely welcome and encourage audience participation using the Q&A or chat features of this webinar software. If you are in your Cisco webinar portal under the tab that says Presentation and you look to the upper right, you should see an icon for chat and an icon for Q&A. If you have questions for our speakers, please use the Q&A function to submit your questions. We will keep an eye for those questions under the Q&A icon. If time permits, we will read questions for our speaker after the presentation. If you have technical or logistical questions, we ask that you submit those using the chat function. Make sure you are identified either by name or participant ID so that our webinar hosts will be able to troubleshoot any problems you're having with audio or other issues. With the chat function, you can choose whether you'd like your comment to be visible to all participants, or you can choose to send the question only to hosts. We extend a huge thanks to Catherine Anzoni and John Wagner and their team who do amazing work behind the scenes to make these webinars possible. They will be monitoring the chat functions today to help with our technical troubleshooting. So just to do a quick time check before I introduce our speakers, do we have Ming Tai-Seale on the line?
Okay.
Yes, lovely to have you. Now definitely I'll start the introductions and we'll work into your presentation. Ming Tai-Seale, PhD, MPH, is a senior scientist at the Palo Alto Medical Foundation Research Institute, or PAMFRI, and is a consulting professor at Stanford School of Medicine Department of Health and Research and Policy. As health economist and health services researcher, her research examines the impact of financial and organizational incentives on physician practices and patient outcomes. She studied the effects of Medicare payment reductions on overvalued procedures using Medicare claims data. Principal investigator of two NIH-funded research projects on how physicians allocate time and effort in office visits, she has developed and applied an innovative method to rigorously examine patient-physician communication captured by video and audio recordings. Papers in these studies won Article of the Year from Academy Health. Since the beginning of the NIA-funded Aging Initiative, she's been serving on its steering committee, and pilot project workgroup and data infrastructure group. Together with Dr. Ellis Dillon and Dr. Christine Ritchie, she's co-PI of the pilot study, which will be presented in today's webinar. Dr. Tai-Seale, thank you for joining us. I look forward to your presentation.
Great. Thank you very much, Dr. Hanson. So thank you, everyone, for joining us. I am going to talk to you about this pilot study that's funded by the HCSRN Aging Initiative on the early signals of uptake of the new Center for Medicare and Medicaid Services payment, advanced care planning discussions, and we also look at historical practice patterns on advanced care planning. Thank you for advancing the slides. Yeah, I first want to just give you the takeaway points because it's a kind of a extensive presentation. That within the first 6 months of the new CMS payments for advanced care planning, a meaningful number of providers at the Palo Alto Medical Foundation began billing for advanced care planning. And historically, we have seen that the majority of patients with serious advanced illnesses neither received palliative care nor do they have advanced care planning in digitally extractable places in the electronic health record. And patient and physician factors were associated with use of community-based palliative care services that occurred in the Palo Alto Medical Foundation. The third take-home point is palliative care services significantly increased advanced care planning documentation in the EHR after we applied propensity score weighting. Next, please. I want to acknowledge a wonderful team of colleagues who have contributed to this study and our co-authors on the paper that we will submit soon, and also to Pragati and Jane for helping with extracting the data from the EHR. We certainly thank NIA for funding the Aging Initiative and to Dr. Gerwitz for his support. So the pilot study is funded by the Aging Initiative, and my co-PI is Dr. Dillon, who is here with me. Next, please. Okay, so this is, for those of you who are not from the Healthcare Systems Research Network, is just a picture of the participating member organizations. Many of those participate in the Aging Network. Next, please. The Palo Alto Medical Foundation is located in Northern California. It's a not-for-profit, multi-specialty, ambulatory group practice. There's about 1 million patients, and it's an affiliate of the Sutter Health organization. Thank you. So in terms of institutional background, the Palo Alto Medical Foundation has a community-based palliative care program. Is organized, really structured, and uses a team care model. The goal is to enhance space treatment, assist with decision-making, is rendered along with life-prolonging treatment, or can be rendered as the main focus of care. The philosophy of care for the PAMF palliative care program is to prevent and relieve suffering and improve quality of life. The program was rolled out in a staggered fashion over time, beginning with Division 1 in Santa Cruz in February of 2011, to Division 2, the Palo Alto Division, in June of 2012, and Division 3, that's the Camino Division, in January 2013, and Division 4, the Alameda Division, in October of 2014. Next. So he just, it's a stock photo that we found on the internet. Wanted to put here just to give us some context in terms of who we are talking about. Can all relate to a picture like this when we think about loved ones, our friends, or acquaintances who are seriously ill with multiple chronic conditions and with many preference-sensitive decisions that need to be made. So I just wanted to take this opportunity for us to see the human side of the research subject that we're addressing today. You can think about, in terms of advanced care planning, that is very much needed for patients like the one we just saw. Advanced care planning is a process that ideally contributes to documentation of patient preferences through advanced healthcare directives and/or physician order for life-sustaining treatment. HCD would include living will or medical power of attorney, and host would include, 3 main sections. That one is a CPR, another is a treatment preferences, whether it's full or select or none, and also the last one is artificial feeding. Just to further motivate our study, patients with multiple chronic conditions and serious illnesses receive care often from multiple healthcare teams, and they be in various locations. They may be in different systems even, or they be in the same system but in different clinics that are, in different geographic locations. Many preference-sensitive care decisions, and it is critical that the medical records document patients' preferences and make them, place them in an accessible manner or digitally extractable. Poor documentation of patient preferences in the EHR could jeopardize the ability of healthcare teams to patients' preferences. We've done some work in this area previously. This is a paper that we published in the Journal of Palliative Medicine in 2013 that looked at documentation of advanced care planning in the electronic health records, and found that they were hard to find and they were placed in different places. And that was based on earlier data. So this study, we're fortunate to have the funding from the Aging Initiative to look at more recent data, to look at whether or not the implementation, in this staged implementation of palliative care program may have improved the documentation of advanced care planning in the EHR. Next. Thank you. So this basically shows that something remarkable happened in January of 2016. This remarkable thing is payment from CMS for their planning. Because some of the barriers that were recognized in literature and also in our previous work, including the IOM report, Dying in America, that was on the last slide, that suggests that providers, in addition to many other barriers, one of the barriers noted by providers is lack of payment for having advanced care conversations. So IOM report actually talked about aligning financial incentives as a essential next step. So in 2016, CMS started paying for advanced care planning conversations. It was highly anticipated. We're very happy that the death panel nonsense is over, and it feels like this is a new era of advanced care planning. Next, please. So we have several research hypotheses. This one is the use of the new advanced care planning CPT codes would increase over time. One is the type of serious illness, location of service, and provider's specialty would affect palliative care service use. Last one is the use of palliative care services would increase advanced care planning documentation in the EHR. Thank you. Here is what we have found based on the first 6 months data from the Palo Alto Medical Foundation. So look at the number of clinicians who had billed the new CPT codes for advanced care planning, and we can also look at the characteristics of the clinicians in terms of at the first 3 months at the end of March, and then the first 6 months at the end of June. There are 2 CPT codes. The first code is for the first 30 minutes, and then the second one is for subsequent 30-minute increments advanced care planning conversations. Dr. Ritchie is going to get in more depth about these codes, so I'm going to save this for Dr. Ritchie, who will be able to explain it much better than I can. Thank you. We can see that there were more female physicians who had built these codes. The total number of physicians that build these codes, the code at the end of first 3 months was 41, and at the end of the first 6 months was 69. And then we had 2 physicians in 3 months and 7 physicians in the first 6 months that built the second code. And we see there's a majority of, okay, next click, please. Then you'll see the sort of the take-home message about this. Catherine, do another click. Oh, okay. No, back one. Thank you. Okay, so basically, there's geographic location area variations. The divisions seem different rates of clinicians using these codes. Majority of the clinicians built for these codes were primary care physicians, as actually you can see from medicine, internal medicine, and with some palliative care or hospice physicians billing them. Very small number of geriatric medicine physician or pulmonary, just one. And we don't see any oncologists billing for these. So this is just a very, just very like a fresh off the data from the data bank that we have of the early uptake of these codes. Next, please. All right. So now to more historical data, we looked at PAMF patients with serious illnesses. The inclusion criteria are as follows: that they needed to have had at least one clinical encounter in the years 2013 and 2014. And as of December 31st of 2012, they need to be 65 or older to have had at least one serious advanced illness. And we wanted to have a clean window because this is an observational study. We were not randomizing patients into palliative care or not. So we required a clean window of patients who had not had care planning documentation in their EHR, and also they had not used palliative care services. So we were observing in these 2 years in this patient population with serious illness what kind of pattern of use of palliative care services and the pattern of documentation of advanced care planning, and also trying to look at the association between the use of palliative care services and care planning documentation. Next, please. Okay, so the definition for serious illness is based on the MCCs palliative care and hospice quality of care measurement set. We used ICD-9 codes at that time because the field was still using ICD-9. Searched in the problem list, which is the most digitally extractable field for both for advanced healthcare directives. Please. List. This is an eye chart, but it basically shows you the list of the advanced care planning codes or terms and ICD-9 codes that we have used in our search. Please. So this is on the advanced care planning documentation rates among the seriously ill patients with and without palliative care. So you see that among the 3,444 patients who met our inclusion criteria, only 6% of them had received palliative care. 9% of them did not receive palliative care in those 2 years. And look at the first column, we see that among patients with palliative care, a very small percentage of them had advanced healthcare directives, but high percent, like 30% of them had POST, or 31% of them had both POST and AHCD. 10% of them did not have either AHCD or POST in the problem list of the HR. And column basically shows that of 94% of the patients who were seriously ill who did not have palliative care, you can see 89% of them did not have either form of advanced care planning. Shows the characteristics of patients who received palliative care versus the patient who did not receive palliative care. You can see they are quite different. That we must try to account for selection bias into palliative care. Again, this is an observational study. So we used propensity score methods. We used both weighting and matching. And the two methods produced a pretty similar results. Next. This table shows the characteristics of clinicians serving the patients palliative care versus without palliative care, and you can see there are some differences here as well for clinicians. Next, please. The plot of ACP documentation rate over time, and we split them out by ACD versus POST, patients with palliative care versus without palliative care, and you can see it is self-evident with palliative care, the rate of patients having their planning grew a lot faster over time in these 2 years, 24-month period. Next, please. The empirical method, beyond the descriptive statistics, we used generalized estimation equation, logistic regression, to add the probability of patients receiving palliative care service. And we use a propensity score weighted GE model to look at the factors associated with having advanced care planning documentation. The unit of analysis is patient month. Please. So the probability of receiving palliative care, and age seems to be a factor. Patients with cancer are a lot more like, really very, very much more likely to receive palliative care. And the patients with advanced dementia also are much more likely to have received palliative care. Higher number of physicians seen the baseline period is also significantly associated with the probability of having palliative care. Next, please. Okay. And this shows the propensity score density. If you could click on it, and you can see that the first one is before weighting. Thank you. The next one shows after weighting. So propensity score weighting made the two a lot alike, the patient population. Next slide, please. This shows the propensity score weighted GE results. You can see that for advanced healthcare directives, palliative care participation increased the odds ratio 14 points. Next click, please. Yeah, for POST, the odds ratio was a 175. So participating in the palliative care program or receiving care from palliative care clinicians greatly increased the probability of patients having advanced care planning. Next click, please. yeah, what I would just said. So receiving the community-based palliative care, those patients were more likely to have accessible both AHCD and pulsed. Next. Looking at the physician characteristics, please click in. So just to remind you, this is propensity score weighted, but we see that there's still remaining significant factors. Click in. Ability of having accessible AHCD and pulse increased over time, you can see. And the palliative care flagship site, which is Division 1, highest rate of documenting pulse. Please. So, summary. There's a meaningful number of providers who began billing for advanced care plan using the new CPT codes since January of this year. And there's still a high percentage of seriously ill patients who do not have accessible advanced care planning documentation. And a very small percentage of seriously ill patients used palliative care. And the use of PAMF's community-based palliative care services was associated with significantly higher rates of documentation of advanced care planning. The flagship palliative care site had the highest pulse rates. Also, over time, the probability of having accessible ACP increased. So this is a story of glass half full or half empty, but it's half full and it's growing because the number of ACP documentation has been growing and the number of physicians billing for the ACP codes has been growing as well in just the first 6 months. Next, please. This is a quote that we heard while we were having a project team meeting. Dr. Lai is a palliative care doctor, and when we were looking at the low rate of advanced care planning documentation, he said, we do this after midnight. So that's the context of the work of the physicians in palliative care. I know many physicians in other specialties also do a great deal of work after hours. Next, please. How do we close this gap? We've done some interviews, especially Ellis, Dylan. So we received feedback like, providers would like more visit time. He said we need a quarterback for advanced care planning, and so we needed to provide patients with more resources. Needed to look at system-level problems. Slide, please. So one thing I want to kind of note is the EHR has been seen as one of the solutions for the poor implementation or poor accessibility of advanced care planning. And we know there's been quite a lot of public and private investments into health information exchanges, trying to enhance interoperability. But in important decisions, advanced care planning has to be placed in the EHR first before it can be used in subsequent decision making and also for interoperability. We have some, I think, evidence in the literature about team care being a promising approach to increase the likelihood of advanced care planning documentation. And, patients may benefit from opportunities to discuss advanced care planning with multiple members of their care team. Please. So I will stop here.
Thank you, Dr. Tai-Seale. Now we'll move to our second speaker, a certified geriatrician and palliative care physician, Dr. Ritchie, Serves as Professor of Medicine at the University of California, San Francisco. She is Medical Director of Clinical Programs in the UCSF Office of Population Health. She directs Tideswell at UCSF, which seeks to transform and personalize healthcare to meet the needs of older Americans and their families. She chairs the National Institute for Nursing Research funded Palliative Care Research Cooperative Group and directs the Pilots and Exploratory Studies Core for the UCSF Pepper Center. She is immediate past president of American Academy of Hospice and Palliative Medicine. She works with other colleagues to facilitate the growth of clinical programs and research that focus on quality of life and healthcare delivery models for those with chronic serious illness and multi-morbidity. Dr. G.
Thank you, Dr. Hanson. So I'll spend a few minutes reflecting on Dr. Tai-Seale's work, first starting with sort of what advanced planning is based on sort of our new guidelines for codes. Second, who likely would most benefit. And then finally, how do we help increase documentation of preference-sensitive treatment with so that patients and their loved ones get the care that they want. So as a reminder, and just to expand on what Ming mentioned earlier, the Advanced Care Planning Act that went into effect in January of this year finally made reimbursement a part of the advanced care planning discussion for healthcare providers when they were talking with their patients. And unlike some of the codes that we've had before, the transitions of care codes and the management codes, provided much more flexibility with the advanced care planning code and did not specify as many requirements around frequency or sort of how even advanced care planning had to occur in order for this code to be used. To rate the code numbers and what they mean, the 9497 code is the code that is used predominantly for the first 30 minutes of a face-to-face meeting that's discussing advanced directives, with 9498 code being used for either additional 30 minutes beyond the 99497, and in addition to that, completion of those forms when performed. One of the interesting things about the advanced care planning codes is that they do not have to be billed on the same day as other E&M services. The providers that can bill codes still, however, are only what are considered quote-unquote eligible professionals, so MDs, nurse practitioners, and PAs. Again, back to sort of the flexibility of the ACP codes is that although they can be part of the annual wellness visit, they don't have to be part of the annual wellness visit. What's attractive about integrating advanced care planning conversations into the annual wellness visit is that the annual wellness visit does not have the 20% copay, so it sort of takes some of the sting out of that particular visit for the patient in terms of their financial reimbursement or financial cost for advanced care planning. So the what of ACP, now let's go to sort of the who's of ACPs. That is, it's going to be difficult if already providers are spending, night hours documenting their services provided for patients to appropriately engage in these advanced care planning discussions with everybody. So who should they be targeting? And that's where there could be some value in thinking about who most likely would benefit from having their treatment preferences known. And certainly most of us would argue that it's those who are the sickest. Often those who are the sickest are also those who end up being the costliest to the healthcare system. Many of you have probably seen this slide in some form or other. It just highlights the fact that there's actually a fairly small percentage of the patients in the U.S. population who account for a large proportion of the cost, and the individuals tend to be those who are sickest and likely those who would most benefit from having frank conversations about what they care about when they are having to make decisions about treatment at the end of life. Next slide. So So end of life, as all of you who are participating in patient care know, is that sometimes it's very difficult to actually identify when someone is at the end of life. And indeed, many people who might benefit from having their treatment preferences known might be those individuals who are at the last year of life, but who are seriously ill for a longer period of time. And this report, the study that actually was put together by Diane Meyer and Amy Kelly at Sinai, and looked at those individuals who were the costliest, identified 3 different groups of people. A meaningful but smaller proportion of individuals who truly were at the last 12 months of life, a group of individuals who were ill and then got better, which is the 40% number, the 49%, and then this 40% group was a group who are chronically seriously ill. And if you go to the next slide, you can sort of see who those people are. And so the next slide. And of course, a conversation about multiple chronic conditions, so we would be remiss in not talking about multiple chronic conditions. But the individuals are not only those with multiple chronic conditions, but those who have multiple chronic conditions and functional limitations. Those are the individuals who tend to be the costliest for the healthcare system and who often have a lot of needs that are unmet. Next slide. This, again, this population of individuals who not only have multiple chronic conditions, but have multiple chronic conditions and functional limitations. And you can see that multiple chronic conditions alone is not an adequate indicator of the individuals who are the highest utilizers of care. And then we think about targeting populations who would benefit from having frank conversations about their health care and their healthcare future, not only to the number of conditions, but how those conditions are influencing their functional status is quite important, and an important message, I think, for us to convey to healthcare providers. Next slide. Another thing that a lot of times folks don't appreciate is that those individuals who have dementia also tend to be high utilizers of care and are often likely to have other multiple chronic conditions. And their cognitive impairment influences their ability to engage effectively with the healthcare system, and they benefit early on from having conversations about what's important to them so that they're right-sizing the care that they receive going forward. So, who are those individuals for whom advanced care planning may be most appropriate? It's probably the folks that are in this slide. So clearly those who have serious illness, but also those with significant functional impairment, multiple chronic conditions, and dementia. Now, we learned from Dr. Tai-Seale's work that advanced care planning documentation is much more likely if individuals are receiving palliative care, and certainly that's not all too surprising for 2 reasons. One is because those individuals who are receiving palliative care are likely to be among the sickest, and second, one of the tenets of palliative care is understanding treatment preferences and goals of care. The question is, if that's part of what helps assure people are having their treatment wishes understood, how do we actually integrate palliative care more effectively into the community? Next slide. Some features of palliative care, based on some of the work done by Jen Timmel and others, is that for palliative care to be effective, it requires rapport building, understanding of the illness experience, addressing symptoms, and then only after those issues have been addressed to have appropriate discussions around resuscitation preferences in hospice. Next slide. Look at where palliative care is the most robust and where we have a lot of gaps. We can see that it's most robust, not surprisingly, in hospice care, but also in hospital care. And happily now, over 80% of hospitals that have 350 or more patients have an inpatient palliative care program. The places we don't have palliative care are those places that are sort of in community setting, office practices, long-term care facilities, and home-based medical practices. The Medical Foundation has really been on the cutting edge of engaging a robust community-based palliative care practice, and that's part of what makes this study meaningful and instructive. Next slide. This shows sort of what an outlier the Palo Alto Medical Foundation practices relative to other practices in the state of California. In a recent survey that went out to hospitals that had inpatient palliative care programs, only 18% of those hospitals had an outpatient palliative care program, and if they had a cancer center, they were more likely to have an outpatient palliative care program. Next slide. When you look at those 18 of adult outpatient palliative care programs, you see of those 18%, only 19% had pediatric palliative care programs, so even smaller number of services there. When you do a deeper dive into these services, though, you see that they really are not serving still a large number of the patients who probably need their care. They have very small amounts of staffing, there's usually some level of wait time, and most of them see a very small proportion of those individuals who would benefit from palliative care within their own healthcare system. Next slide. So implications of the findings that we've recently heard from Ming and her colleagues. Well, first of all, is that time constraints and provider self-efficacy do serve as meaningful barriers for people to engage in advanced care planning. The second is that community-based palliative care certainly can help with advanced care planning documentation, but it's going to be insufficient, and that the work probably that needs to be most focused on in the future relates to targeting of those populations who would benefit from advanced care planning, development of effective communication strategies for frontline providers to engage in advanced care planning discussions, and the use of person-centered planning tools like Prepare for Your Care, which is a tool that was developed by one of our colleagues here at UCSF, Dr. Sidori, that can help with mainstreaming advanced care planning. Next slide. Script is to say that this work was really catalyzed by this relationship between HCSRN and PEPR centers and highlights the value of research collaborations of all types. One of the things I hope that we will continue to do in the future is to continue these kind of partnerships that we have now developed between HCSRN and the PEPR centers, and think about other research networks like the Palliative Care Research Cooperative Group that can help us answer some of these important and thorny questions that can be difficult to answer in one site alone. And we'll stop and we'll be happy to answer questions. Thank you.
Thank you so much, Dr. Ritchie and Dr. Tai-Seale. If you have a question, remember that your phone has been placed on mute, so please type your question in the Q&A section. Thank you. Like we have a question of a certain slide. So the question is, what is the denominator or total sample size for these categories in the slide?
In this slide? So there are about 1,200 physicians at the Palo Alto Medical Foundation, so it's like 3 to 4% physicians.
So while we're waiting for more questions, please continue to type your questions. Can I just ask you about a patient perspective? Reed had a colleague who on his own decided he wanted to complete these forms and bring them to his physicians, and did research on his own, found his advanced care directive, went through conversations and brought it to his physician in the clinic, and nobody seemed to know what to do with it. You know, in thinking of a patient who would like to make his wishes known, what recommendations do you have of healthcare system or physicians, and how do handle this when you don't have a systemic approach perhaps in place yet?
Yeah, Christine, do you want to take that question?
Happy to. Also, I'm sure you have some really important perspectives on this as well. So, very difficult to effectively do this work without engaging in systems-based change. And one of the challenges is figuring out sort of where are the levers that are going to be the most effective and that will have the greatest push and to contribute to that change. Certainly, having a place in the electronic medical record is important. Being able to monitor often how well these advanced care planning discussions are occurring and their impact are going to be important. And a big piece is have a system in place that allows for ongoing education with booster sessions to healthcare providers, their sense of self-efficacy around every facet of advanced care planning discussion process. And, certainly, those of us who are part of the UCSF healthcare system, this is something we're actively reflecting on and trying to think about important approaches to addressing. And there are, from the world of implementation science, stress that can be brought to bear, but it really means understanding the important context of a particular health system and particular practice to contribute to effective change. May I ask that?
Oh, you could add a little bit about, based on my understanding of how the Palo Alto Medical Foundation has been addressing this. So with the palliative care program, the system started with actually putting a standard location in the ER for advanced care planning, and it looks like a hot pink, which is the color of the post form. So if a provider were to click on that button, he or she would be able to see ACP healthcare agent, whether this patient had an agent, and then there would be a scan document section, so you can see if they have a post, if they have advance directives, living will, attorney, and when it was entered, when it was scanned in, and there would be a section on the ACP filed document, the type of document, status. So previously, this could be all over the place. Like if you go to scan document, a patient with serious illness who's in their 80s could have hundreds of scan documents. It'd be very hard to through and find the most current advanced care planning document. So standardized location, basically in the default window, the client can see the advanced care planning button and then click on it and then can see all the documents and the relevant information. So standardization is innovation. I think something that we, learning health organizations are increasingly, doing more standardization of workflow. So it's just really very, very important, and to take specific ways. I've seen, like, walking the halls of the clinic, sometimes I would see a patient come in with a daughter, and in their hand they would be waving this post form because it's hot pink. It's such an important step they've taken, and they would ask the clinical staff where who would take this, and then they would be guided to, you take this to your visit, and your doctor or the medical assistant will sit in, and then it will be available in the EHR.
So a question about differences in tools across states. Is there any initiative to standardize these tools? There's so many to choose from, confusing state to state. Can you address that on a national level?
And I'll follow up.
I think it is really important. I think there are some initiatives. I don't know about like a public efforts. I think, Christine, you will be much more able to give a more authoritative answer to that. I know of some, private foundations effort in trying to have like electronic pulse repositories, and there are, state level regulations, but I think, Christine, you have a much more about what's going on at the national level.
A number of things going on. It is absolutely true that every state has their own advanced direct form, and they often are driven by the cultural and political norms of the particular state and region. And so it's my guess that they'll never have one unified advanced care directive across states, although many states will recognize other forms that have been utilized across states. The more promising work along those lines, in my mind, relate to the Physician Orders for Life-Sustaining Treatment initiative, which is not for everybody. It really is focused on those individuals who have a limited life expectancy and have some serious illness. But there are increasing numbers of states that have adopted the pulsed paradigm, and even though they might not all look exactly the same, each state again is able to adapt the pulse to their particular liking and even call them different things. So I believe in Massachusetts, for example, it's called the MOST form for medical orders for sustaining treatment. Nevertheless, they're enough alike that they provide some level of standardization. But it is confusing and difficult, and there are a number of initiatives that are going on across the country to try to at least create a clearinghouse for state-by-state advanced care directives, so it's not so difficult to access the one that's relevant for a particular patient where they reside.
Tai-Seale, can you comment, do you have any results on the percentage of patients who decline having advanced planning conversations with their clinician?
I do. That's a really important question because our study was based on electronic health record. We were only able to find the referrals or the discussions that yielded in the documentation. So it's a very important question, and we hope to address in the future.
Do we have questions from our webinar audience? Please type them in the Q&A box in the bottom right. Thank you, Dr. Ritchie and Dr. Tai-Seale, for an engaging conversation about palliative care today. We really appreciate your time and sharing with us the results of your pilot study funded by Aging Initiative and talking about your collaboration in the broader field. Really appreciate it. Thank you so much. For those of you who are listening to the webinar, as you close your screen, you'll be prompted to take a survey. We really would appreciate your feedback and what you thought of our webinar today. These slides and the webinar will also be available by a link that you should receive via email. If you have questions or would like more information about the Aging Initiative, there'll also be an email that you can use to reach out and connect with Catherine and direct you to the appropriate place. Thank you both again for your participation today.
You're welcome. Thank you for having us.
Thank you.
Good day, everyone.
Thank you.